Mark. It's great to be here virtually. So many happy memories of my fellowship in New York. Bob taking us all out to eat at the diner in Bellevue. Getting to learn from Dr. Goldfrank, especially at Journal Club. Learning from Maria and Marianne and Lewis. Back then, Silas and I were co-fellows together to put some time perspective on this. And Mark, that was the several year hiatus when he wasn't at the Poison Center, Mark Sue, although we got to know each other really well. And we actually bumped into each other at the beginning of the New York Marathon, unplanned, and ran 24, 25 miles together. So you really get to know a guy when you run 25 miles with him. So it's great to be back at my second home. I'm going to talk about the toxicity of anti-cancer immune checkpoint inhibitors. And this is going to be a very clinically applicable lecture. This is something that you are going to see throughout your careers moving forward if you haven't seen it now. And there's going to be a few key points I'll make sure you remember, and then the rest is just some cool science and cases to put some meat on it. I have no conflicts here, no disclosures. I'm not interested in anything. What are we going to do today? We're going to learn about the mechanisms of immune checkpoint inhibitors. We are going to teach you all how to recognize the toxicity from immune checkpoint inhibitors. You're going to learn how to manage checkpoint inhibitor toxicity. And another big practice change is that for every cancer patient, I'm going to want you to find out if they've ever been on a checkpoint inhibitor moving forward. So that's going to be something maybe new for your practice. So who am I? Mark introduced me well. How do I know specifically about this topic? How did I get interested in it? So I'm on the Johns Hopkins IRB. Been a co-chair of the IRB and a pharmacy and therapeutics specialist on the IRB. And I noticed these drugs as research drugs, these checkpoint inhibitors, maybe 6 or 7 years ago. And then I started noticing them in patients that I would see clinically. And I've noticed more and more, we're seeing more and more of these drugs in the clinical setting. And it's been interesting to learn about their toxicity and learn, how they differ from standard chemotherapy toxicity. And just backing up a second, this is important. So like many of you, I learned in the old paradigm of anti-cancer drugs, which is that most anti-cancer drugs are cytotoxic chemotherapy. They interfere with cell growth and division, right? And when we see people that took those drugs, we worry about low cell counts, we worry about infections, we worry about fever. We especially worry about cytotoxic chemotherapy within 7 to 14 days after they took it. If they haven't taken it in a few months, then that's probably not causing their problem, right? And so I'm here to tell you today that paradigm does not hold true for these checkpoint inhibitors. They are completely different types of drugs. And so while cytotoxic drugs are still out there, they're still being used, regular chemotherapy is still a mainstay of cancer therapy. These checkpoint inhibitors work completely differently, and they're very important, and you're going to need to know about them. So this is really like immuno-oncology. This is the level that we need to know it. Immuno-oncology 101, right? You got T cells. They attack stuff, but when they see immune checkpoints, these are PD1 on the T cell, which binds the PD-L1 on the presenting cell. When it sees when it sees something that binds CTLA4, it sees this as like a password where it knows not to attack it. So if you have the password, the T cell won't attack it, right? And so your body may say, well, it's an older code, but it checks out, right? And as a toxicologist, I have to make at least one like science fiction reference per lecture. So don't get your hopes up. There aren't too many more of these. But if you inhibit the inhibitors, if you inhibit these immune checkpoints, you turn up the T cells. So we're inhibiting the inhibitor. You turn up the T cells, you're inhibiting the stop sign, and the T cells go from stop to go. And you get them to attack more stuff. And that's what checkpoint inhibitors do. They get T cells to attack more stuff by inhibiting these receptors, PD1, PD-L1, CTLA4. That's really all you need to know. They get T cells to attack more stuff. And when T cells are attacking more stuff, they're attacking more cancer cells. which is good. And they're also attacking other things, which isn't good. Now, in the case of a cancer cell, it might be a trap, right? Because the cancer cell is presenting these passwords, and the T cell, which should be attacking them, isn't. So when you inhibit it with a checkpoint inhibitor, you turn up the T cell and get it to attack, right? This slide is probably a little more than you need to know. Screenshot it or something, but just know that when T cells are primed, CTLA4 is a more important receptor. And when C cells are taking action, PD-1, which binds to PD-L1, is more important. You really need to know more. This one's got way, way, way too much. Screenshot this one and memorize it later. Impress all your immunology friends and oncology friends. But really just know that checkpoint inhibitors inhibit the inhibitors. They turn up T cells through these receptors, CTLA4, PD-1, and PD-L1. Now, these immune checkpoints, these are associated with immune-mediated disease already. So we all, as I've said, we have these PD-1 receptors, we have CTLA4 receptors, and they're already associated with immune disease. Diabetes, right? Immune attacks on your beta islet cells. Celiac disease, myasthenia, lupus, rheumatoid arthritis, right? And we've known this for years. So it was known as soon as checkpoint inhibitors started to get developed that there was a chance that they could cause these kinds of problems. Because when you're making T cells attack stuff, it's not just going to attack the cancer cells. These immune checkpoint inhibitors are already out and among us. So patients that we are seeing are taking these medications now. These are not just investigational medicines. And these are actually just the approved one. There's a lot more that are investigational. They all have names end with mab: nivolumab, pembrolizumab, atezolizumab, avelumab, durvalumab. The oncologist might call them Nivo and Ipi for like nivolumab and ipilimumab. There's a lot of approved combinations. And in some cases, they're approved in combination with chemotherapy. So some patients are going to be taking checkpoint inhibitors, a single agent. Some people are going to be taking two agents, a PD-1 and a CTLA4. Some people are going to be taking a checkpoint inhibitor and chemo. So you gotta ask. Of course, patients don't know necessarily what a checkpoint inhibitor is. So I take a multi-pronged approach here. If I see a mAb on their med list, I Google it. A lot of patients have a wallet card. You can talk to their oncologist. You can look in the EMR. But there's a lot of different ways to find out that they're on these drugs. But it's important to know not only that they've been on it, that they're on it now, but if they've been on it in the past. So we'll see. So these drugs are approved to treat a whole lot of different cancers. So this is important just to give you an idea that this isn't, I'm not talking about rare medications. These are a lot of different kinds of cancers, a lot of solid tumors in general, whether it's different lung cancers, a lot of melanoma, Merkel cell, renal cell, liver cancer. So a lot of different cancers, a lot of different drugs, a lot of patients more and more are going to be taking these drugs. And they tend to be second and third line drugs, although there are a few indications where these are indicated up front. So a reminder, right, about monoclonal antibodies. In toxicology, we're used to a lot of Fabs, which is just the binding portion. A monoclonal is the whole antibody, including the FC part that binds complement. Monoclonals differ from standard small molecule drugs. So small molecule drugs means regular drugs, right? Like diltiazem or penicillin or something like that, right? Small molecule drugs tend to be less than 500 Daltons. Monoclonals tend to be greater than 150 kilodaltons. They're monstrous. They're huge. Small molecule drugs are given orally. Monoclonals are given IV, sub-Q. Rare indications where they're given PO for some gut stuff, but essentially always injected. Small molecules have variable distribution. Monoclonals have 3 to 8 liters per kilogram volume distribution. Small molecules, we know, they're eliminated by your liver, by your kidneys, freely eliminated. Monoclonals tend to be eliminated by the receptor they bind to, right? And finally, small molecules, right? They can last seconds, like alfentanil. They can last days, but monoclonals tend to last days. So that's why, if you have somebody, that's taken a monoclonal or taken an antibody injection, they might get it once every week or two. So take durvalumab, for example, pharmacokinetics. It's got a volume of distribution of 5.5 liters per kilogram, half-life of 17 days in the serum. So it's dosed over 60 minutes, but it's given every 2 weeks. In some patients, it might be given every 3 or every 4 weeks. So these are drugs that you're coming in, you're getting an infusion at this cancer center. Because of this, we don't really hear about a lot of overdoses. I haven't seen a case. I've seen cases where people get the infusion faster than they were supposed to, but this isn't something that somebody's gonna unintentionally or intentionally overdose on at home because it's a drug that you're getting in an infusion center. I'm going to go back and forth between these two terms, immune-mediated adverse reaction, IMAR, and immune-related adverse events. They're the same thing. These are just words to describe the toxicity of these drugs. So immune therapy is different from standard chemo, and this is something I want to keep banging on. So chemotherapy, typically you're going to see high-grade toxicity. Immune therapy, it's a lot of low-grade toxicity, thankfully. Chemo, it's dose-dependent. Immunotherapy, it's variable, right? Chemo, few organs are affected. Generally cells that divide fast, right? GI toxicity, people lose their hair, cells that are dividing. Immunotherapy can attack any organ, and we'll see. Chemo, it's a well-established time course. Within a week or two of getting your chemo, you might get toxicity. With immunotherapy, real important here, real important to remember, it can happen at any time after you've taken your first dose. It can happen within weeks, days of taking your first dose of checkpoint inhibitor therapy. It can happen months after stopping your last dose. So you take your last dose, you can get toxicity 6 months later. Your immune system has a memory, right? I got my measles vaccine when I was a baby. I still have antibodies against measles. Our immune system has a memory, and that's how checkpoint inhibitors work. These immune-related adverse events can attack any organ system. So people can get diabetes, pneumonitis, renal toxicity, eye toxicity. Your immune system goes anywhere. So if you turn up your immune system, anything can get attacked, right? Any immune-related disease that can happen from these drugs. Why and how do they occur? A lot of bad luck, right? Just like everything else, we don't know. Folks with autoimmune disease might be more likely to get more toxicity. People with subclinical inflammation from something else, like an infection. Shared antigens might play a role. Combination therapy. So if you're on Nivo and Ipi, nivolumab and ipilimumab, you're more likely to get it from just one alone. Makes sense. So any organ can be affected, as I said. So when you see patients on checkpoint inhibitor or that have been on it in the past, I want you to expand your differential. So you see that person with a history of checkpoint inhibitor therapy and they have diarrhea. Don't just think, could this be C. diff from the antibiotic they were on last week? Think, could it be colitis from a checkpoint inhibitor? You see somebody with a cough and shortness of breath. You don't just think, could this be COVID or pneumonia? Think, could it be pneumonitis from a checkpoint inhibitor, right? Headache could be hypophysitis, which is pituitary inflammation. Rash, maybe cellulitis, maybe dermatitis from their checkpoint inhibitor, right? Fatigue, syncope, shortness of breath could be myocarditis from their checkpoint inhibitor. And I've seen all of these in the clinical setting. So this isn't just theoretical, this is real. So we're just taking our old differential and we're just adding things to it. Many patients are going to have some immune toxicity, about 90% of patients on CTLA-4 drugs, 70% on the PD-1 drugs. The distribution of these, tends to be a lot of endocrinopathies, pneumonitis, colitis, and hepatitis. So I said, anything could happen. You'll see a lot of rashes, pneumonitis, colitis, and hepatitis. That seems to be most of it. When do they occur? Again, anytime following starting the drug. May present after the first dose. It may occur months after the last dose. So you don't just say, oh, what drugs do you take if you're cancer? You got to look in their EMR and see what they've been on in the past, right? Sometimes it's helpful to talk to their oncologist. When do they occur? As I said, the timing, it can be variable. Rashes tend to be the first thing to be seen. Diarrhea tends to be, closer to a month or two out. Pneumonitis, 4 months out. Then once you get months on from treatment, any of these things are possible. All right, so again, toxicity can start after the first dose and it can be long after the last dose. I'm going to talk, every now and then you're going to be talking about grades of toxicity. This isn't something I ever learned until I started hanging out with oncologists. It's somewhat useful. Grade 1 is mild, no medical therapy is needed. Grade 2 is a little worse. Grade 3 is a little worse, generally needs hospitalization, and grade 4 is potentially life-threatening. Grade 5 is death. And these are used a lot in research, and it's actually used a lot to determine how to treat these reactions. Just remember, one isn't bad, and 5 is the worst. Now, here's some good news. I've got a message of hope. So I've been telling you all the bad stuff about checkpoint inhibitors. What's really fascinating is that toxicity, if you get one of these toxicities, it's actually associated with a good outcome for your cancer treatment, which is, kind of blows your mind until you think about it, that it's because if your immune system is making toxicity, it also means it's active and it's activating things. And that means it's also attacking the cancer. So you see this red line, which is survival of people on checkpoint inhibitors. They get toxicity, and it's higher than the black line. So the survival is better if you actually get some adverse events. So kind of really, really interesting, a little bit counterintuitive until you think about it. So that was my first message of hope. I got 2 messages of hope. My second message of hope is that the treatment for all of this is pretty straightforward. And that treatment is corticosteroids. So we're not going to be asking you to get familiar with some exotic medication for your first-line treatment. For the most part, we are going to be treating it with the kind of medications that we use all the time anyway, steroids, right? We use them for asthma, we use it for allergic reactions, we use steroids all the time. Generally, grade 1 toxicity may not need any steroid treatment. Grade 2 might need oral steroids, grade 3 might need IV steroids. And so on and so forth. So, just getting up to, maybe 1 to 2 milligrams per kilogram per day as you get up to these high levels, or these high grades of toxicity. So supportive care might be somebody with a mild rash. You might just say, oh, let's just keep an eye on it. If it's a little bit worse, we might put some topical corticosteroids on it. I'll give them some prednisone. If they have severe dermal toxicity with skin sloughing, they'd get high-dose IV or steroids, right? So the worse it is, the higher doses you're giving, the more steroids you're giving by parenteral route. Guidelines for steroid therapy. People that need to be on these for a long time, we like to taper them. Sometimes people need to be on them for long term. Of course, we don't rapidly taper. They need blood glucose monitoring if they're on it for a while. We're about adrenal insufficiency when we stop. Gastritis prophylaxis is needed, PPIs. Look out for opportunistic infections for patients that are on it for more than 4 weeks of more than 20 milligram prednisone equivalent. So they might need antifungal or PJP prophylaxis. Osteoporosis is something we worry about in people that are on it for a while, right? So steroids, the decision to start steroids shouldn't be taken lightly, but for a lot of higher grade toxicities, they're going to need it. We're asked a lot about how do the steroids affect the efficacy of the therapy? I'll talk about that in a second. 90% of patients on steroids will get more than one adverse event. 55% on steroids are going to say the adverse event was bothersome. And how does it affect the efficacy? So preclinical data suggests that steroids reduce the efficacy. So steroids, preclinical data, animal data say that steroids may make the checkpoint inhibitors not work as well against your cancer. Clinical trials actually don't find that. So in people, we find steroids do not hurt the efficacy against your cancer. Steroids reduce naive T cells, may have little impact on effector or memory T cells. That may be why. Early steroid use may decrease efficacy. So what does all this mean? It means that we only start steroids when you need them, right? Because a lot of people would think, well, if steroids prevent checkpoint inhibitor toxicity, shouldn't everybody that's on a checkpoint inhibitor be on them? And the answer is no, because even though they may not decrease efficacy, at least not after you've been on the checkpoint inhibitor for a while, we know that they do increase the chance of toxic effects, side effects from the steroids. So if you're starting steroids on somebody taking a checkpoint inhibitor because they have checkpoint inhibitor toxicity, they're going to say, wow, isn't this going to mess up my checkpoint inhibitor? And you can say, I don't think it will. Steroid alternatives. So if steroid don't work, there are backup plans. Mycophenolate, which interferes with purine metabolism, infliximab, anti-TNF, tocilizumab, you hear about it a little bit for COVID nowadays, the IL-6 antibody, and immunoglobulin, which neutralizes autoantibodies and downregulates chemokines and cytokines. These are our backup plans. This is another screenshot. By no means, we're going to go through this one by one. Just know that this is what you do for people where steroids don't work. And for each toxicity, there's a different best practice right now. So for diarrhea, the best practice might be to go to something called vedolizumab. For pneumonitis, the best practice after steroids don't work seems to be immunoglobulin. For most people, steroids work. So what's the summary of this? This is the first half of our talk. Checkpoint inhibitors, if all you remember are these points, I think you're great. Checkpoint inhibitors are monoclonal antibodies used to treat cancer. Checkpoint inhibitors turn up your immune system. They make your T cells go. Checkpoint inhibitor toxicity can occur at any point after administration. Checkpoint inhibitor toxicity can occur anywhere in your body. You can get colitis, you can get pneumonitis. Anywhere your immune system goes, it can get toxic. Checkpoint inhibitor toxicity is actually associated with a good response to cancer therapy. Checkpoint inhibitor toxicity is treated with corticosteroids, although the corticosteroids may not reduce the efficacy of the checkpoint inhibitor. So if all you remember is this, you're golden. That's really what I want you to get out of this. We'll go through a few cases now. I got a couple of cases just to cement it and see how this works in your practice, right? So you got some 77-year-old man, lung cancer, trouble breathing. So he said he had sinus congestion, was seen in urgent care a week ago, given antibiotics. He's got cough, he's got chest tightness, he's got shortness of breath. We've all seen a dozen patients like this, probably recently. Medications include warfarin, albuterol, he's had a DVT. Current therapy is atezolizumab. So you Google atezolizumab and you find out that is a checkpoint inhibitor. His temp is 99.9, heart rate 102, blood pressure's okay, setting 92% on room air, a little bit hypoxic. He's a little bit tachypnic with a respiratory rate of 24, bibasilar RAES. Of course, you get a COVID PCR on these guys, and this one's negative. Chest X-ray shows bilateral infiltrates at the bases, pleural effusion. He's anemic, otherwise unremarkable. So we've seen this patient before. Make a differential. Could be pneumonia. Could be worsening lung cancer. Could be pulmonary embolism. Maybe the infiltrates are just a red herring. But we've taken this old differential. Now we add something new. This could be immune-mediated pneumonitis. So what are the next steps? Administer oxygen, CT the chest, talk to the oncologist, right? Get them involved. They can be a real ally in letting you know a little more information, helping you admit the patient. So this guy's oxygenation improves with supplemental oxygen. The chest CT shows new ground glass opacities. And so COVID's not the only thing that's associated with the word ground glass, pneumonitis as well from checkpoint inhibitors. The effusion was unchanged from a prior scan. Lots of different images you can see on CAT scan, lots of different radiographic presentations. But how are you going to manage this? So at this point, we have no other information. Let's say you're an emergency physician managing this patient. You're an internist. This is a higher grade toxicity, so you give methylprednisolone IV. You're going to give antibiotics to cover a pneumonia that may be there. You're going to admit them to the hospital. And then down the road in the hospital, there will be further respiratory virus testing, sputum culture, and a palm consult to try to sort out whether this is in fact checkpoint inhibitor toxicity. So the key point here is you made your differential, it was your same old differential, you added checkpoint inhibitor toxicity, you treat checkpoint inhibitor toxicity, even though it's going to be days before you figure out whether it was that. Right? It might not be till you get a lung biopsy, it might just be a response to therapy. how's it going to be treated? So lower grade toxicity, you might just hold the immunotherapy and check imaging again in a few weeks. Higher grade pneumonitis, grade 2, empiric antibiotics, methylprednisolone, consider bronching them, getting more blood work. If no response at 3 to 4 days, they're going to increase the level of therapy. Again, so just we do more stuff at higher grade toxicity. Grade 3 to 4 toxicity, they'll probably never get on immunotherapy again. They'll probably stop it permanently. Do an infectious workup, again, get the pulmonologist involved, bronch the patient, do bronchoalveolar lavage, empiric antibiotics, and they'll be on methylprednisolone for a while. If that doesn't work, infliximab is currently favored second line, mycophenolate and IVIG be given as well. So that was the first case. So we had a patient with pneumonitis. The first doctors to see him, whether it was in the office or in the emergency department, weren't able to make the diagnosis for sure, but they were still able to start steroids and get the person admitted appropriately. So case number 2. 60-year-old woman, history of kidney cancer with fatigue. Right? We all see people with fatigue all the time. She's got a headache. We all see you with headache all the time. Otherwise, negative review systems. Been on antidepressant for a year. Are you taking any medications? No, I'm not taking any medications. Right? But now, because you've attended this lecture, you know to ask the next question, which is, have you ever taken any medications for your cancer? What have you gotten in the past for your cancer? You do some medical record searching, and you see that she was on combo checkpoint inhibitor therapy that was stopped 4 months ago. So she was on nivolumab and ipilimumab. Temp 98, heart rate 112, blood pressure 90/50, respiratory rate 22, O2 set 98%. She's got a mild headache, maybe orthostatic, but otherwise normal. So our vital signs are a little concerning. We don't like tachycardia. We don't like the mild hypotension. But it's kind of a benign exam, unremarkable, non-focal exam. CT of the head in this patient with a headache and cancer is normal. We get some basic labs. And if we're looking closely, we see this mild hyponatremia and hyperkalemia, right? And we remember that makes us think about all sorts of adrenal insufficiency. So what's our differential, right? Our old differential, right, could be brain metastases. She had a history of cancer. She's having a headache. Maybe it went to her brain. But these labs have us thinking about immune-mediated hypophysitis, which is pituitary inflammation, and immune-mediated adrenal insufficiency. Right? So because we know about checkpoint inhibitors, because we looked in her EMR and found that she'd been on this in the past, we knew to take the next step. Right? So how are we going to manage this? Fluid resuscitation, prednisone. Talk to our endocrine friends, whether up front or after they get hospitalized. They're going to tell you to get cortisol, ACTH, and pituitary hormone levels, and an MRI of the brain, get cellular cuts to see if it is in fact pituitary. And here's a great case of ipilimumab-induced hypophysitis. You see here, this is a big old pituitary, and this is a smaller one. So same patient after treatment with steroids. So endocrine, immune-mediated events. This was adrenal and pituitary dysfunction. MRI of the brain, hold the immunotherapy, start methylprednisolone, and replace other endocrine hormones as necessary. So a lot of these are team approaches, right? So for that case, you're going to need a lot of help from your endocrine friends, right? So because these are multi-system drugs, really takes a multidisciplinary approach. So our third case, this is our final case. This is a woman aged 70 years with metastatic thymic cancer. It's another real case pulled from the literature. She's presenting with exertional dyspnea, no other medications, but you ask, what have you taken in the past? And you see that 3 weeks ago, she got her first dose of pembrolizumab, which is a checkpoint inhibitor. So vital signs, temp 98, heart rate 112, blood pressure 150/80, respiratory rate 32 per minute, very tachypneic. And this oxygen saturation is 98%. They bring the EKG to you, and it looks really scary. You see right bundle branch block pattern, but that's not the worst of it. T-wave inversions, and one in AVL. But most concerning, ST elevations in these precordial leads that really suggest anterior MI. Right? So this person gets rushed off to the cardiac catheterization lab. And the troponin indeed is positive, but the coronary angiography surprisingly reveals normal anatomy. Right? So now it's up to some poor CCU intensivist to figure out what's going on in this puzzling case. Clearly somebody really sick, clearly somebody experiencing cardiac toxicity, but maybe not a typical MI that they're used to dealing with. And this turns out to be myocarditis, right? So this is hematoxylin and eosin staining. And all this pink stuff, that's muscle, that's good. That's what you want to see. You don't want to see all these cells. That's inflammatory infiltrate. And that is a sign, that is myocarditis. This is, pathologists will tell you this is myocarditis. You can also diagnose this with MRI, which is obviously a lot less invasive. It's very sensitive, very specific. This patient had a myocarditis. And, I myself saw one of these a month ago. Patient presented to an emergency department with about a month of fatigue. So it wasn't just like this acute chest pain. It's just like a month of fatigue and shortness of breath. Troponin was elevated. EKG just looked non-specific, and we admitted him to the CCU, but the patient had been on nivolumab, and it was determined. So after they did the standard, they did coronary angiography, they cathed them, and it was negative, and it turned out to be checkpoint inhibitor toxicity. And we actually had started him on steroids in the emergency department. And we got a big thank you from the oncology team and the cardiology for doing that, because that's not part of their standard practice, but because we had asked about the checkpoint inhibitor, we were able to do that. So this one has a little plot twist now. So this person does have myocarditis, and they're intubated during the initial evaluation because they were just so sick. But in the ICU, they could not wean them. They were having trouble pulling the tube. This patient also had myasthenia gravis. Neurology was consulted. Acetylcholine receptor binding and blocking antibodies were found. So we started this patient on pyridostigmine, started this patient on corticosteroids, and got them in for plasmapheresis. Now, this isn't common. However, this combination, this myocarditis, myasthenia gravis combination, is not as uncommon as you would think. These two go together frequently with checkpoint inhibitors. They're both muscles. That may be the connection. And I've seen one of these folks as well. Thankfully, the person I saw actually carried the diagnosis. But these people are around. This isn't as much of a zebra as you think. So myocarditis can be seen alone. Myasthenia gravis can be seen alone. They both can be seen together. Now, this one has a happy ending. This patient was weaned from the ventilator after 50 days. Now that person's not happy to be on a ventilator 50 days, but the CT showed significant resolution or decrease of all metastatic disease. So this whole time, right, this patient was not on checkpoint inhibitors, will never be on checkpoint inhibitors again. But as I said, your immune system has a memory, right? Not only that, but we said earlier that having toxicity actually makes you more likely to do well with your cancer. And that's what we saw here. So somebody who got super sick, somebody had myocarditis, somebody had myasthenia gravis, like prolonged hospitalization, actually continued to have benefit from their cancer, even when they're off active therapy, just getting ICU care. And from a cancer standpoint, they did a lot better. So myasthenia gravis with checkpoint inhibitors, less than a 1% incidence. 85% of these people are going to have anti-acetylcholine receptor antibodies. 8% will have anti-muscle specific tyrosine kinase antibodies. You're going to also think about Eaton-Lambert myasthenic syndrome, right? Somebody with cancer and muscle weakness. But what's our treatment? It's steroids, right? Our first line thing is steroids. We're going to get our neurologist friends involved. We're going to get the oncologists involved. But the first step, the first thing that we can do to help these folks is to give corticosteroids, something that we're all familiar with, something that we all use almost every time we work clinic. Myocarditis checkpoint inhibitors. Less than a 1% incidence. Diagnosed with biopsy, but you can also diagnose with MRI, sensitive, specific, not invasive. Treat with what? Steroids. Second line treatment might be immunoglobulin, mycophenolate, and infliximab. So we're winding down. We've talked about 3 cases. We've talked about what checkpoint inhibitors are, how they fit in to cancer treatment. And if you've kind of lost your focus, you've zoned out, come back to me now, because we're going to give you the bullet points again. So 1, checkpoint inhibitor toxicity can affect any organ system in the body. Anywhere your immune system goes, it can be attacked. So remember our key points again. Checkpoint inhibitors are monoclonal antibodies used to treat cancer. Checkpoint inhibitors turn up your immune system. They tell your immune system to detect more stuff. Checkpoint inhibitor toxicity can occur at any point after starting it. It can even occur after stopping it. Right? So you haven't been on your atezolizumab for a few months, it doesn't matter. You can still get dermal toxicity from it. Checkpoint inhibitor toxicity can occur anywhere in the body. Right? So if you have a patient with a problem, it could be from the checkpoint inhibitor. Doesn't mean it has to be, but you take your same old differential and you just add checkpoint inhibitor toxicity to the end of it. Just keep it in the back of your mind. Checkpoint inhibitor toxicity is actually associated with a good response to cancer therapy. So, when you're admitting these patients, when you're consulting on these patients, you can give them a message of hope. Even though it stinks that they're feeling sick today, that it's actually in some ways an expected part of the therapy. It's a little bit of a setback, but in the long run, it could be helpful. Checkpoint inhibitor therapy is treated with corticosteroids, right? Our second message of hope, which is that you don't have to use anything exotic or fancy first line. We all use steroids all the time. Steroids, steroids, steroids. Steroid inhibitor may not reduce checkpoint inhibitor efficacy, probably doesn't. So when you're starting the steroids and the patient says, oh, I don't know, geez, I really want to be on this medication, you can say, no, this is going to help with the toxicity. We don't think it makes the drugs less effective. And finally, ask your patients about their cancer meds, not just what they're taking now, but what they've taken in the past, because your immune system has a memory. Checkpoint inhibitor toxicity can occur months after you stop. Thank you all for having me here. And I want to thank my colleagues here at Hopkins, Evan Lipson. Drew's going to do some oncologists that I work with. We've given this lecture together in the past, and peer review education, which lent me some slides from their talk on checkpoint inhibitor toxicity. So with that, I'm happy to answer any questions.
Well, Andrew, thank you very much. That was wonderful. We do have a question from the audience, from Kathleen Clancy. Here you go. Would you give steroids if there was an overdose of any of these agents, or would you wait for symptoms? And as you mentioned, uncommon since it's parenteral. So what do you think about overdose?
Yeah, I would wait. I would wait. As you nailed it. It's uncommon. It would have to be something that would occur, in the infusion center in general. But I would just wait and see if there was any toxicity, then treat from there.
So Andrew, how long would you wait? Since this toxicity can occur at any time point, how long would you observe? What's the process, the length of the observation?
Yeah, so the as we saw earlier, these drugs stay in your body for a while, and we know that in overdose, that can push out of any drug, that can push the pharmacokinetics of any drug and make it last even longer. It's not really practical to keep somebody in a hospital for days and days and days if they're not sick. So I would in the first 6 to 12 hours, keep them in the hospital and watch for allergic type acute events. If nothing happens, I would just send them home with instructions for close follow-up.
Okay, that's good. We have another question here. I think this is from Suzanne Doyon. What about other checkpoint inhibitors such as ocrelizumab used for the treatment of multiple sclerosis? Can you comment on that?
No, I haven't come across that one specifically, and I guess that just shows, you know, how much how new these drugs are, and how there's some every day. We see a lot in my IRB. I hear about a lot of other investigational checkpoint inhibitors. There's a lot coming down the pipeline, and you know, each company seems to want to make their Me Too drugs. So you know, there's going to be new CTLA-4 drugs, new PD-L1 drugs, but I haven't heard of that one. But I can say of all the ones that exist, I look at the consent form and the toxicity profiles for all these drugs. The toxicity profile is very similar for all of them. They all tend to do the same things.
Very interesting. Thank you. Okay, so no other questions right now from the audience. But Andrew, I have a question. As you described, since the checkpoint inhibitors can affect pretty much any organ system and toxicity occurs anytime, how do we confirm this diagnosis of checkpoint inhibitor toxicity when these happen? Because these patients obviously present with they're very sick and a lot of things are going on. So what's the process? Is it just a diagnosis of exclusion? What do we do?
Yeah, so you're absolutely right. And if you're an acute care doctor, if you're an internist or an emergency doctor, if you get a call from the poison center, you're not going to be able to make a conclusive diagnosis, right? That pneumonitis, they're not going to know for sure that it's a pneumonitis and not a bacterial pneumonia or some other kind of pneumonitis until later on they get some tissue from the lung, right? Whether they bronch them, right? But we give a lot of steroids up front in the absence of contraindications, right? So somebody comes in with pneumonitis, I'm going to still give the antibiotics for pneumonia, but then I'm also going to give steroids. Now, I'm going to talk to the oncologist. I think they're usually the biggest ally, because they can help communicate with the other services and talk about how the checkpoint inhibitor fits in with the other drugs they're taking. But in most cases, you're treating these like right up front. We saw a case of meningitis. So we gave them antibiotics, we gave them steroids, and it wasn't until days later that they concluded that it was the checkpoint inhibitor. So you won't know right away. You're going to need the sub specialist to get the tissue or just conclude that that's what caused it.
So Andrew, when I'm in the emergency department and I'm working as an ER physician and I see a patient, if I see one of these checkpoint inhibitors on the list of medications and they're sick, should I presumably just start empiric steroids at that time, or what do you think about that?
Yeah, depending on what they're sick with and how sick, for sure, right? Okay. If you see a cellulitis and you're just, this is clearly a cellulitis, then you're not going to treat it. But if you see some weird rash that you think could be immune-mediated dermatitis, then treat it. And I think what's really important for those of you who are going to be working in the emergency department is if you, just from listening to this lecture, you now know more than most of the interns and medical residents that you might be calling to admit the patient to, right? And so sometimes they might say, well, oh, geez, why'd you give steroids to this patient? Just hold on, maybe let's not give steroids right away. You can find yourself in the role where you're teaching them, no, actually, this looks like this could be checkpoint inhibitor pneumonitis. We won't be able to conclusively diagnose them. It's indicated to start it now. So we're starting steroids now. And they might not know. This is still something that people are learning about. It's not in everybody's medical school. It's not in everybody's residency curriculum just yet.
So Andrew, fine discussion. Could you answer whether if you cut back on your therapy because someone had this initial response, is the next event this person has going to be the same organ system or another organ system, or can they have several simultaneously?
You can have several simultaneously. Most people do not recur after treatment. And so I might have said earlier, depending on how severe the adverse event was, a severe adverse event, they'll just never start the checkpoint inhibitor back up again. If it was a mild adverse event, they'll start the checkpoint inhibitor up again. They will start it up again. People mostly do not recur. Some people do recur, but when they do, and even though you can have two different organ systems, most people, if they recur, they tend to have the same organ system.
Okay, we have another question here, Andrew, for you from, I think, a former attending of yours, probably Jason Chu. How far removed from these checkpoint inhibitors do you not think it's a problem? How many months or years?
So, yeah, Dr. Chu taught me everything I knew when I was a resident. So the short answer is we don't know for sure. We've seen people get sick a year and a half after not being on the drug anymore. So, 1 to 2 years, but because realistically, right, or from a very practical standpoint, these have only been around, like FDA approved, for I think 5 or so years, maybe a little bit more. We still don't know. We don't have a top end. So I think after 1 to 2 years of the last dose, it starts to probably get more unlikely. But the teaching that I've still gotten is it can happen at any time afterwards.
Okay, anytime. That's a long time. Okay, good. What's this question here? Sorry, I can't read it. Are you able to share your experience with immune checkpoint abrupt discontinuation or withdrawal?
I actually we don't see any adverse events. So people usually only stop these. So the way these tend to be used is people tend to be on them indefinitely. So people that get checkpoint inhibitors tend to be folks with a cancer that resisted other standard chemotherapy, and second or third line people with metastatic disease. And so when they're getting these drugs and they're working, they tend to just stay on them. The people that stop them are people that had toxicity. But no, we don't. So, you stopped it because you had bad pneumonitis. You stopped it because you had really bad colitis. But we don't see people getting withdrawal from stopping it. We don't see any kind of like immune deficiency from, right? These drugs turn up your immune system. It's the immune deficiency from stopping it. And a related question that I get is, do these drugs, because they turn up your immune system, do they make you less likely to get infection? And unfortunately, the answer is no. You're still just as likely to get infections when you're taking these drugs.
Okay, and we have more questions I see in the chat now, in the question and answer, Andrew. What about if given the wrong route? If does that have any experience with that? Or extravasation? Any problems with that?
No, we haven't seen any. I've seen some adverse events reported to the IRB for extravasation, and they just handled it with elevation and like cold packs. So I haven't seen any. There wasn't any necrosis or anything scary like that.
And what about wrong route?
No, I haven't seen any wrong route. No.
Okay. And how do you answer the question or worry about steroids decreasing the efficacy of antibiotics?
Yeah, so people ask me, like, if we're giving some, so a lot of these patients are really sophisticated, right? Because they've had cancer, they were either in a clinical trial or they've gone through chemotherapy, and so they really want this checkpoint inhibitor therapy to work. And so they do get concerned, is this going to make my therapy not work? And what I tell them is that, clinical research shows from clinical trials that starting steroids doesn't make the checkpoint inhibitor any less effective. I tell them, look, we don't love starting steroids because steroids have their own problems. They have their own toxicity, might make your blood sugar more likely to get out of control, et cetera. We want to keep you on these steroids as short a time as we need, but right now it's important to treat your toxicity, and we don't think it's going to make the checkpoint inhibitor work any less. But yeah, people are they are always concerned.
Okay, and I think we'll do maybe one last question here, Andrew. So here's a comment. Infection will obviously be behind the differential for many of these patients, and many will be immunocompromised for other reasons. such as chemotherapy. But are these patients known to be at increased risk of infection from the checkpoint inhibitor therapy alone?
No, they're not. So I said earlier, they're not at, unfortunately, they're not at decreased risk, but thankfully they're not at increased risk. So, you know, some of them are on chemotherapy. Most of them are just on checkpoint inhibitors. And the interesting thing is that unlike, you know, like I was saying, our old paradigm of cancer drugs make you immunocompromised. Not so for checkpoint inhibitors. So it's just a different paradigm.
Andrew, what does this cost the patient, the system?
These are pricey. These are expensive drugs. I don't have the number. I don't have the number in front of me. But hopefully, you know, it'll continue to come down because, you know, I'm not working for any of these companies. I'm not, you know, I'm not conflicted in that way, but they are remarkably efficacious. Like you see people with certain kinds of melanomas that used to just be fatal. You see a lot of like real meaningful survival increases, and most of the toxicity is mild. So these are great drugs. And so, yeah, I take your point. You know, the cost of oncology drugs is exorbitant, and it's unreasonable. And so hopefully we'll be able to figure out a way to make this therapy affordable and available to people, because I think it really does add meaningful increase to a lot of people's lives.
Do the Me Too drugs differ substantially in their results, or is this just a marketing effort?
No, just marketing. Yeah, they look for other indications that haven't been sought out by the other companies. But you know, oncologists they can a lot of them will see past that, and they'll try off-label indications, you know, for some of these drugs if they think it'll be helpful.
Thank you very much.
Yeah, thank you, Andrew. Any last questions from the audience? Oh, here we go. One more. Mark Silverberg. If they work so well, can they be given first line with other chemo?
Yeah, there are some cancers, I don't know off the top of my head, where they're starting to give it up front, which is really exciting. And you know, there is some hope. People have probably been saying this for decades, that this kind of therapy, these kind of targeted therapies can move us past chemotherapy, right? Because some chemotherapy can be very successful, but obviously carries a lot of toxicity with it. But for now, in many cases, these are still, you know, second and third line.
Wonderful. All right, Andrew, thank you very much again. It was an amazing lecture. I myself learned a lot from this. Really appreciate you having here. As I said before, you can stay on and continue being a panelist. And if you ever come back to New York City, let's run New York City Marathon again together.
Sounds great. Thank you.
All right, take care. All right, guys, we're going to come back at 2 o'clock to start Consultants Conference. Thank you.